the person that I know of that's doing that kind of work is Russ Johnson in Minnesota. You might want to talk with him. Yeah.
Tissues, the spirochetes that you recover from tissues, are they positively identified as Borrelia burgdorferi?
All of these were identified by Alabama's monoclonal antibodies. I should have mentioned that. Yes.
You're indicating that a number of times spirochetes were found as reported on a biopsy in histopathology. Is that something that they're routinely looking for, or are there specific requests made when the sample is submitted to look for that organism?
If a physician called us about possible Lyme disease, if I talked to him and he said there was a rash of some sort, then I asked him to do that. And I explained to him how he should submit it. And by the way, that we asked them to ship it overnight in about a mil or a half mil of either BHI or thioglycolate because it's readily available in their lab. And then we would get it into culture as soon as possible. Does that answer your question? Yes.
I'm impressed by the frequent mention of fleas. Have you been doing any work on fleas themselves, going out to survey, or any idea what species? Or
it's the cat flea that we find most often. We do collect fleas during these investigations, but we have no studies showing how effective transmission is.
Just in reference to fleas, I see lots of dogs and lots of fleas. And strangely enough, a lot of times dogs will come in with, quote, hot spots. I've had a couple that have had what I call malignant hot spots, I mean covering their entire rear ends. And that's where fleas tend to be. And these dogs, you do find fleas on them and they're positive for Lyme.
I see. Any other questions before I go on? This next talk is, I consider all aspects of Lyme disease interesting, but this is the first part of it's going to be historical, and I hope that you find it as interesting as I do. Do we have the... Multiple sclerosis was first described in 1832, and today it is the primary cause of incurable paralysis affecting young adults in temperate climates. Symptoms range from a slight blurring of vision to complete paralysis. Other symptoms include tingling sensations, numbness, muscle weakness, unusual fatigue, incoordination, and spasticity. The diagnosis of MS is in part based on evidence of lesions in the central nervous system caused by the loss of myelin. These lesions or plaques can occur almost anywhere in the brain or the spinal cord. Symptoms usually appear between the ages of 20 and 40. The disease has a predilection for women, whites, and those of a higher socioeconomic status. The environment appears to play some role in the epidemiology of the disease, as there are areas of high and low frequency. MS is found more often in the colder climates of northern Europe, southern Canada, and the northern United States. Here, incidence rates are 30 or more per 100,000 population. In low-frequency areas, such as Asia or the tropics, incidence rates are around 5 per 100,000. And a person's risk for acquiring MS has been linked to where he or she spends the first 15 years of life. The cause of multiple sclerosis is not known, but there are currently several theories being put forth. The leading hypothesis is that MS is an autoimmune disorder linked to a common viral infection, such as measles. A slightly different version suggests that a slow virus present in the brain triggers a state of altered immunity. Despite extensive research, there is no conclusive evidence for either of these hypotheses. Interestingly, according to an MS researcher by the name of Leibowitz, MS is no more an immune disorder than neurosyphilis, a disease in which immunoglobulin is synthesized intrathecally and which is diagnosed by the presence of autoantibody or reagent in the serum. Now this leads me right into a third hypothesis, that spirochetes play a role in MS. As early as 1911, Farquhar Buzzard, I love that name, wrote that MS, or disseminated sclerosis as it was called then, resembled cerebrospinal syphilis. He suspected that DS was caused by an organism similar to the treponeme. In 1927, Isabel Wilson tried to link DS with leptospirosis. She felt that there was a possible association between the heavy incidence of the disease in agricultural and other outdoor laborers with rats and water. She said, "It is possible that variations in the life cycle of the spirochete are responsible for the small total incidence in the population," and meaning that she felt that one phase of the organism was infected. And for the failure of many investigators to find the organism would be attributed to the fact that, or what she felt was one stage being non-spirochetal. She felt that the organism was carried by rats, was excreted by them into water, and where the water was stagnant, the spirochete developed its infective phase. She felt that the organism gained entrance to the patient by penetrating mucous membranes or the skin, and that this entrance was facilitated by continuous dampness of the skin and probably also by abrasions and dermatitis caused by the patient's occupation or otherwise. Now, about this same time, researchers began demonstrating spirochetes in animals that had been inoculated with the tissue of MS patients. In 1921, Blaylock and Adams inoculated rabbits and subsequently found spirochetes in the internal organs. Now, one might argue that they were in reality seeing the rabbit spirochete, Treponema caniculi. And sure enough, they did find these spirochetes in control animals, but they felt that these were morphologically distinct from those detected in the test animals. One of the biggest proponents of the spirochete theory was Gabriel Steiner. He maintained that MS is an infectious disease caused by specific spirochetes different from any other spirochete, including those of syphilis, leptospirosis, and relapsing fever, though he did feel that it was Borrelia-like. He called this organism Spirocheta myelophthora, the myelin sheath-destroying spirochete. Steiner suggested that these were short-lived organisms rapidly breaking into fragments or granules that were picked up by lymphocytes. This resulted in the formation of silver cells, and these silver cells could be demonstrated in cases of dementia paralytica, a late manifestation of syphilis, and MS. He found that what looked like the true spirochetes in approximately 25% of MS cases, and in every case of dementia paralytica. Now, those opposed to the spirochete theory argued that organisms seen in MS patients represented artifacts and saprophytic contaminants. Much more recently, George Dick and Derek Gay have proposed that multiple sclerosis is caused by oral spirochetes. Now, actually in the 1930s, Herzog and Vail separately found an association between sinus infections and either optic neuritis, which is common in MS patients, or MS itself. And in 1977, a higher recorded rate of chronic and relapsing nasopharyngeal infections in MS patients when compared to controls was reported. Taking this a step further, Dick and Gay postulate that during sinus infections, Treponema denticola invades the central nervous system from submucosal microabscesses. So what about the association between Lyme disease and MS? It is well known that Borrelia burgdorferi can cause a variety of central nervous system abnormalities. And in the last couple of years, there have been numerous reports of MS-like illness caused by this spirochete, as you can see by this list of references. I've begun my own study of the possible association between MS and Lyme borreliosis. My hypothesis is that some cases of MS may truly be misdiagnosed cases of chronic borreliosis. I began testing 3 groups of specimens: 90 MS patients, 75 family member controls, and 174 age and sex match controls. In the beginning, I used the IFA, for which a titer of 1 to 256 or greater was considered positive. This was because I didn't know what the 64s and 1 to 128s meant. There can be some nonspecific reactions. Here, 14% of the MS patients had positive antibody titers, while 5% of controls and 6% of the matched controls were positive. I moved on to an EIA or a LISA, and 6% of the patients were positive and 6.7% of the controls were. Now, I do find that the EIA is slightly more sensitive, but when a previous titer of 1 to 64 or 1 to 128 by IFA was confirmed by EIA, then I went ahead and moved it up into the positive range. That's why we have a higher percentage of positive. So it would appear that MS patients are more likely to have been exposed to some spirochete, whether it be Borrelia or some Borrelia burgdorferi or some cross-reacting species. Now, most of the patients and family member controls were also tested for rubeola or measles antibody, since this virus has been thought by some to play a role in MS. As one might expect, 23% of the patients had elevated antibody titers, whereas 5% of the controls had high titers. Now, of these patients with elevated rubeola titers, approximately 1/2 were also positive by the Borrelia IFA. Thus, it does not appear that there is a correlation between measles virus and spirochetal infections in these patients. 84 of the patients and 74 of the family member controls participating in this study did complete questionnaires. Each was asked if he or she had ever had a severe reaction to a tick or flea bite so that a big red circle formed around the bite. 14 patients and 11 controls answered yes. Unfortunately, only 12 patients and 7 controls remembered when they had this reaction. As you can see from this slide, when the patients remembered when they had had the reaction to the bite, it tended to be many, many years ago. When the controls remembered when they had had a bite or a reaction to a bite, it tended to be fewer years ago, and they tended to be a lot older when they were bit. Participating physicians were asked whether their patients were in remission or if disease was present. 71 of them answered, and of these, 43 patients had disease present at the time the serum was drawn. Of these 43, 42% had detectable antibody and 14% had positive titers. This is by the IFA. 28 patients were in remission. Of these, 28% had detectable antibody and 3% had positive antibody titers. From this, it seems that serum antibody titers could be rising during exacerbations. So, in summary, it seems that researchers have been theorizing an association between MS and spirochetes for a long time. Recent reports in the literature suggest that Lyme borreliosis mimics MS, and this certainly could leave the door open for misdiagnosis. My own study shows some association between MS and Borrelia antibody. And finally, MS patients tend to recall having erythema migrans or possible erythema migrans early in life, and perhaps this fits in with the risk associated with where a person lives their first 15 years of life. Are there any questions about this?
You had several different types were described. Do you see any correlation between the different types and the ones that have positive types?
I have the physicians were asked to tell me what type of MS they had, and I have that data, but I didn't see any correlation, so I don't have the slide.
Are there any thoughts of evaluating or looking at histocompatibility issues?
I don't have plans to do that, but certainly I plan to contact the physicians again in the next month or so to ask if they treated any of these patients and what they thought about the results of the study, and perhaps, I can ask them that question as well. Okay.
Has anybody looked for titers in CSF food?
I think that would be a very good idea, and perhaps these physicians may have gone on to do that, but I felt like when I asked physicians to send me these things, that if I asked them to draw a spinal fluid on every patient, that I might not get the numbers that I needed. So, I didn't do it. Yeah.
You know the immunoglobulin class is G or M
For
those that were reactive?
Yeah, for the eye, no, I did not distinguish between the two. Any other questions? Thank you.
So we take a 15.
Called a modified barium swallow, and I want to emphasize the word modified. I know you in the medical profession are probably very familiar with the barium swallow or upper GI series, in which you are laid flat down on a table and gobs of gallons of ill-tasting barium are poured down you. And if you can survive that, you probably don't need my services. The modified barium swallow is done in a more natural environment, swallowing environment. The person is sat up, and in this case, a high chair was used. We also use real food to do this swallowing study, and it's often called the cookie test. I know it's a cookie baby sometimes, affectionately by the radiology technicians, or the pudding test. And there are three reasons that we do the test. One is that we're looking for aspiration. The second is that we're trying to target intervention for swallowing difficulty. And the third is that we're looking at nerve involvement, either from a central nervous system disorder or from a lesion of cancer in the area itself. And the reason that I got involved is because Jamie is Karen's son, has a lot of problems which seem to be in the mouth area. There's a whole syndrome of them, and she has asked me to follow them. The test is done in the hospital with speech. It seems speech has picked it up because there's a big hole in that. Dentistry is interested in the oral area, and GI like the esophagus, and there's a big hole kind of in between in which speech people have gotten involved in doing this particular kind of test. And so today, what I want to do is I want you to become acquainted with the test. You'll probably know more about swallowing than you ever planned to know in your life. I want to review a case study of a child with the late effects of congenital Lyme disease. It's Karen Forshner's little boy, who you'll be seeing quite a bit of. And I would like to encourage you to use it as, or to include it in research studies to take a look at the cranial nerve damage that can come from Lyme disease. And it was interesting. I've only seen it with children. I guess Dr. Rollin talked about it with speech difficulties with an adult, which is the first I've heard of an adult having this particular kind of effect. However, with children with Lyme disease, we're seeing it much more frequently as part of a syndrome, and it seems to be a very, very difficult one to deal with, especially as children get older with swallowing. They have a lot of problems getting down, they get aspiration. And it's a very nice bonding effect with mother and child to be able to feed your child when you have a G-tube in, which is what happens if you can't swallow, to lose some of that effect. So let me get you acquainted with the area in question. This is if you, okay. This is if I took you as a sagittal view, if I slice you in half. Look, I just want to acquaint you with, there's three areas of the swallow. This will help you in interpreting the test that I will show you a little later. The oral area is this large area right here. The tongue is this very large part up in here. We have the sulci up in here, which is between the teeth and the lips. Oftentimes you'll see this food getting stuck in here. There's also a sulci, which is the part of your cheek is over here. All this is considered the oral area. Back here you have what's considered the pharynx, or the back of the throat. This is your uvula, the thing that sticks down and you go, oh, into that. The epiglottis is here, which is another structure that helps tighten down so that the food goes down into the stomach, which is back here, as opposed to the food going down into the lungs right here.
You can see that if you have any problems with the cranial nerves or any problems with innervation back here, that you could easily, the food easily can take a wrong turn and go down into this area rather than going down into the stomach area. This is just a picture to show the amount of nerve innervation. There are a very active area for the nerves that are involved, and specifically, not a very good slide, in fact, you can hardly see it. We have 6 nerves that are involved. We have the trigeminal nerve, which is involved with muscles of mastication, biting, some of the ability to, oh, there we go, at the top, it's hard to see. Trigeminal nerve that is involved with the ability to open up the mouth. You also see it down here, the ability to elevate the larynx. You also see a little bit of, up, I guess it's in the sensory, you've got the trigeminal up in being able to taste and be able to feel the tongue. And there's also the facial nerve, which involves the lip, the ability to hold the lip in shape for eating. We also have a little bit of it down here with the laryngeal activity, being able to move the mouth around. The glossopharyngeal muscle is another one that's involved with the shaping of the tongue and the laryngeal activity. The vagus nerve is very, very active in the larynx and is a whole swallowing mechanism. In fact, it's very much caught up in the esophagus, and we see quite a bit of it. Also, again, in just moving the muscles in the throat and being able to voice or cough. It in particularly is sensitive to cough reflexes, and that's a sensory part of the back of the throat, and lets people know when there is food in the back, so you cough like that. Spinal accessory is also another one that's involved. Again, it's some sensory functions, again, some of the pharyngeal activity, and the hypoglossal, again, is involved with some of the tongue and pharyngeal area. So we have basically 6 cranial nerves that are involved, and we take a look at the modified variant to take a look at what's going on. Now, this is a study of the child. All things nice. What we're going to see is, we're going to see this on the test, so I do want to show you what a child looks like. The structures begin to change. You'll notice here that the tongue is picked up a large part of the mouth, that the down here is the areas of the larynx and of the throat are tucked up closer, much closer to the tongue than you see in an adult. You also see the jaw is got a nice straight across angle rather than angled up. And oftentimes, which makes it very difficult for these tests, is that the uvula that's in the back of the mouth and the epiglottis, the other cartilage that protects your airway passage, come together and often are difficult to see on testing. This goes on a little bit, comparing the two, the adult and the child. Okay, I would like to show you what a normal swallow looks like, so again you can see what's going on. I put these in backwards specifically because I can't go from left to right and right to left. I want everything is oriented over here to the right side, so I'm sorry it was backwards, but that's the way I want to do it. The oral stage, this is the white thing is considered the bolus of the food. The oral stage is this part that's in the tongue where someone bites off, chews it, and puts it into the tongue. This again is the jaw. You're going to see the vocal cords down here, difficult to see. You will see a lot of this what's called moleculi, a little space that's formed in the throat. Oftentimes when things are going to get caught, they get caught there. I have patients who cough up pills 2 days later. It's sitting in this little part right here. You will also see in the child is a protective mechanism during sucking. The food comes down here, kind of accumulates until they have enough to swallow, and then comes back down in. Your oral stage. Okay, food goes back, goes back in the throat, comes down to this moleculi. Again, the epiglottis closes over so that you don't get anything coming down into the airway passage. And you get the food going down into the back here, into the esophagus or the stomach tube, coming back down in. And that's considered the esophageal stage. That's where GI gets involved. That's where the GI and also the radiologist get involved. I'm mostly interested in the oral pharyngeal stage, and when it gets down to here, I refer to my colleagues in the gastrointestinal department. All right. Now, this is what it really looks like on X-ray. Let's get down to reality here. It's all very nice to have these nice schematic drawings, but basically this is what you're going to see when you do an X-ray. This happens to be Jane's portion right now. Let me just orient you to it. You can see a little bit about what we're doing. Here's the chin down here. You see his teeth up here, and again, you're going to see some molars and a couple things down around in here. A tongue over here, coming back in. You cannot see the soft palate and uvula down around in here. That's difficult to see. The respiratory, or the back of the throat, the pharynx, is a lighter colored area down here. It's hard to see his hyoid or any of these other structures that are down here. And it's difficult to see the trachea, or you will never see the esophagus. It's an inflatable tube. It only exists on pictures that they draw in books. Okay. Again, this is supposedly what we're looking at. The tongue with the soft palate down here, the colleculi around in here. The epiglottis here, this large structure with the food hopefully going into the back. Okay, this is Janie beginning to do some swallowing here, and you'll see the dark colored structures. Sometimes I get it lost in the teeth, but it's right in here. He's starting to give some food in the beginning. He's got it near his teeth, and in fact, it's falling into the sulci. At this point, he had a fairly active case of like a Bell's palsy, and the food was falling into the front part here where the lips weren't able to assist it to get back. Eventually, does get it back. It's moving back in the mouth. It's difficult to see. Right over here is the bowl or the food. Coming back in the mouth. It's working it back along the tongue. Okay, food is right here. Again, he was a very wiggly kid, so we may put it in the central spot, but he moves around a lot. Again, here's the food going back, going back, going back, coming down into the pharynx now. Continuing down, and look what happens. He goes to swallow, and only half of the food goes down into the esophagus. The other half of this food goes back up into his mouth. Now, this is caused from posterior tongue problems. At the time, it's not only just the face that was involved, it was very much the tongue that was involved, and more likely it was the left tongue side. This you can see from visual inspection, not particularly this one. So he had a very tough time, and again, it shows some of the tongue problems that these children have with swallowing, and that when they go to swallow, they can take extra long, which has only happened, it goes down to the stomach. The other thing that can happen was an interesting one, is that Jamie said, okay, I have a back of the tongue problem, so this is what I'm going to do, is I'm going to put my tongue down. And you'll notice the food is kind of sliding, gravity will help you here, sliding back down, and so he can try, rather than trying to initiate a swallow by pushing it back with his tongue, he's letting gravity do the work. And again, it's coming to rest close to the colleculi. And you'll see now he begins to initiate a swallow by pushing the tongue back and the food back down. And again, getting food with a fairly large bolus distributed patient there. He also, unfortunately, this is a terrible slide. He has what we call a baby bird position, which was the same thing. You'll see some of these kids throwing their heads back because of the posterior tongue problems. And this is a bolus here. They're trying to get it to slide and go down around in here. Jamie also has a problem. He likes to take the food and mash it up here rather than pushing it back and letting it come down. There's been very, very poor studies done on normal children who swallow. This is a very, very early swallow technique that we see mostly in very, very young infants. And Jamie has perseverated in using that. It also might be his lack of food because he hasn't had G2 and has not had a lot of long feeding history here. But again, he accomplishes the same thing by putting his head back. There's the bolus and slowly sliding across and coming down again. Now, the first time I saw him, we have the food coming down here. You can watch it come down. It's kind of sliding down. You'll notice it takes its time back here. That's some of the problem. There's so much weakness here that it kind of hangs out there for a while. That's one of the things about this particular kind of problem. Okay, watch what's happening around here. There's the airway passage, there's the stomach passage. You're going to start seeing a little bit of the food coming down into the respiratory passage during the swallow. It shows laryngeal weakness. Again, that was going to be our vagus nerve involvement. Again, coming down to the lungs, and what this is where it supposedly is schematic. I've always liked these so I can show them back and forth. I wish all my patients looked like this, but they don't. This is the food that's coming down, and it's starting to come down into the airway passage of the food and go into the back of the throat, down to the stomach. And again, what we watch, and we watch, normally we're not even doing that, we would be talking at the store. There was no talking. This went down to the lungs silently. Okay? There was no cough, no cough. We waited, there was nothing. again, vagus nerve involved in going down the esophagus. There's still no coughing. And we wait. Now we're going to take a look at the front view. This normally is what we should see. It's the tongue here, the food up here, the teeth here. And again, getting back to reality, let's take a look at what that actually looks like. This is Jamie again, and I apologize for the quality. And so we were playing around with trying to figure out which one works best. We figured out that this one does not work very well. Let me orient you. Again, these are artifacts. I'm not quite sure how the staples showed up, but they're there. This is the tongue here. What you will notice, how it's much higher on the right side than the left side. You also see a very highly arched roof of the mouth of the palate. And you'll notice, we noticed that when he moved, again, this side was the one that was moving all the time. And the left side, basically, you see that big indentation with the right side moving. Now imagine trying to eat through that, and you're going to get food that goes down over here, where this side won't really work. Now, this is what we saw when we saw him 4 months later after antibiotic treatment, typically on antibiotics. We're getting a much better tongue position. It's very, very nice in crescent shape, with a nice, it's moving very nicely to the shape of the roof of the mouth and the palate. And again, same thing where we see elevation on both sides with a nice working. Along with that, what we also are going to see, okay, is when we brought him back, he took the hospital food with barium in it and spit it back out. You know that. But actually what happened, we had a beautiful radiology study, and we went to take a look at the videotape, and for some reason the machine was not working. And I worked there 5 years and never had that happen to me. So what we did was we took him back into another room with another machine, and he promptly, after being tube-fed, and I don't blame him, promptly began to spit out everything that we tried to give him. So we had to bring him back on the second day. And basically, again, we've got, this is a wheelchair, his things to the wheelchair is metal. Food's coming back here. And you'll notice it's a blur because it's going so fast. You can hardly even see it going down. His oral transit or pharyngeal transit time has improved significantly, we find by about 25%. And we find that, again, notice it goes through very quickly. Then what we're going to be seeing again now is an aspiration piece. We see that when the chin gets cut back, so look what happens this time. As we start to see the shoulders rise, and the food is right here going down in the lungs. At this point, the shoulders start to come up. He's starting to cough like heck, because he's got something down in his lungs. And in fact, what happens is he works it back up even, like you and I would, and you can see it on the video, but not on this. He actually re-swallows it back down, so it actually clears out his lungs. So again, what we're seeing is a significant improvement in their ability to both heal the laryngeal passage, to cough, and to get the mucus or food out. We also see decreased transit time, so that this posterior part can really push it down very, very quickly. That's still. And so basically what we're seeing for this kind of child with Lyme disease, basically what we're seeing with that is decreased tongue control or lingual control with loss of the food over the tongue. When that happens, you can end up with a very severe choking situation, except these kids do not have the ability to cough. They don't have the ability to feel. They don't have the ability to get the food back up. So you end up with a lot of pneumonias. That is probably what we're going to be looking at. This is, again, our test case. It's our first one that we're seeing at St. Francis. We hope to do a few more on some of the children that we're seeing with late effects of Lyme disease. Also, we don't know whether some of the things we're seeing, some of the longer stays in the pharynx and not triggering a swallowing reflex are due to immature swallowing patterns, or whether there's a real problem with specifically with the cranial nerves that at one time perhaps Jamie was swallowing and has regressed. I don't know. We also are seeing some reduced laryngeal closure, which you see with aspiration, and then we're also seeing the reduced cough reflex. Interesting, as I was listening, the symptoms that I'm describing with this swallow are very similar to what we see with both MS and ALS, and it's almost the same clinical picture. So it was interesting that what we're seeing is mimics very much some of the things that we see with our other neurologically involved patients. So that's what I want to show you. Anybody who would like to know more information, ask.
your speech pathologist at your hospital, and they should be able to help you. Thank you. The videotape is available for anybody who wants to take a look at what this looks like in real time. Questions?
I'm sorry, have we had any cases with?
Megaesophagus?
Not yet, no. Yes.
Have you had any cases where people have nutcracker syndrome? I'm not sure what the name is.
Nutcracker, that's a new one on me. Can you explain what it is? Maybe I can tell you we had one.
I believe when they swallow, there's like a spasm in the esophagus or something like that where it really, it really hurts, and they often have to use muscle relaxants to control it.
Sure, but I guess I've never heard, that's a wonderful way to explain it. I love the term, yes. We have had, but again, that's more of a GI problem, and again, I would refer to my colleagues in gastrointestinal for that. The reason we get involved is because we can do techniques to help with the oral and the pharyngeal, or the back of the throat stages. The esophagus is really the area of the gastrointestinal. We'll refer them over to those folks for help.
The next speaker, Dr. Paul DeRay, has been involved in Lyme disease since the early days. He was part of the group studying Lyme at Yale. He has since moved to Philadelphia, where he is the chairman of pathology at the Fox Chase Cancer Center. And what he'll be discussing today is the general pathological aspects of Lyme infections.
Thank you, and good morning, everyone. I can see we're a little behind, so I think that I'll be able to do this probably in a shorter period of time than what your program addresses. If there are questions, I think we would enjoy doing that a little more. And I had planned about 35 minutes, but it occurs to me we can probably do this in about 18 minutes, because many of you know what's about to flow on the screen. And I think that the rest of you who haven't, it will still give you an image of what goes on when the spirochete travels through the human body. This is an anatomy lecture. This will be a picture of what goes on once the spirochete enters the human body. The question of what happens in animals is another question. The question of why what we're about to see happens is certainly a whole series of questions. And what we can do about it and what we can do to intervene about it is a whole series of research talks, of which we're engaged in as we sit here now. Our laboratory is actively working. I'm not going to discuss any of those effects of research or the chemical and molecular research that we're currently doing at Fox Chase, or any of the other special tests that we've done. We've portrayed those findings in bits and pieces in different meetings, but I won't be showing that. What I'm going to do this morning is just take you through a pictorial tour, if you will, through the Grand Canyon of what we call Lyme borreliosis as we understand it in human tissues. This is about to the last time I'll be giving this talk, because in a few months we'll start to move in to show what we're doing in the laboratory level. If there are questions about the research aspects of it at the end of this 18 minutes, hopefully, well, then we can discuss that. But so we will waste a little time with a few extra slides. I used to think that this disease, of course, is not due to Lyme disease, is not due to Lyme's, but I'm wrong. There is a disease that you can get from Lyme's. As this little blurb showed up in the New Orleans Times, actually it came from an observation from Dr. Wayne White at New York University, where it truly, limes do contain, and so do grapefruit and a few other things like celery, do contain a coumadin-like substance that if you rub it on your skin, you will get a dermatitis. I'll say no more about Club Med and this activity of, the slide speaks for itself, but be aware that there is a Lyme disease. We're not talking about that and have not been talking about that. Now, I know Paul Lavoie came all the way from California. I imagine that in California they don't have syringes washing up on the beaches, but we've had a
we've had a tough time here in the Jersey coast this summer. So let's move right into this problem. Initially, once the tick bites, we begin to see a number of things taking place in the skin, and I'm going to give you those terms when we see them, both clinically and pathologically. There in the center of the photograph is the residual of a tick bite, which is what we call the papule, and then the classic spreading erythema migrans rash that you see there. And this would be the pathologic picture of that. Up at the top is our friend Ixodes damoni at the top, feeding on skin. And you notice at the base of the dermis, you can see that there is a pathologic reaction, an inflammation that I think is quite characteristic once the tick's been feeding for that length of time. Now, the classic rash has this circular ring with an outside rim of erythema, and the center part begins to clear, as you can see here. This is not an uncommon place because the tick can obviously hide in hairy regions, as it does here. The thing we have to remember that not all erythema migrans has this classic cyclic appearance with central clearing. Not all erythema migrans has this classic appearance because they can look like sunburn. This is erythema migrans absolutely proven to be from a case from Munich, West Germany, in a forestry worker. And you can see that that does not look like a central clearing, but that is erythema migrans. Here's a man also from Germany with what looks like a laundry dermatitis from his shirt onto his trunk, but that is erythema migrans. And I can tell you, unless you're really looking, sometimes these rashes are not very prominent. And now here, conceivably, that could be this Lyme dermatitis but it is indeed Lyme dermatitis, not from the fruit, but from the tick. And historically, I think 10 years ago, if I'd have seen this in a dermatology clinic, and I did work in a dermatology clinic in Minneapolis, I would have probably called it a yeast infection or a corynebacteria infection or some such. This is Lyme borreliosis, and it is erythema chronicum. And look at this one. This could conceivably be a vector bite, could be a spider bite or something like that. This is erythema migrans with a central small healing eschar. So we know that the pattern varies with the rash in the first stage. And pathologically, the picture is very typical in that you see inflammatory cells, but mast cells and plasma cells make up the type of cell response that comes into the dermis. And it hugs the vessels for a very clear reason. At the end of the talk, I think you'll understand why. But this looks like the histology of any rash, with the exception that there are plasma cells there, and those are the cells making the antibodies. Here's another patient with erythema migrans. If a pathologist was particularly dull in that afternoon, and we're all accused of that from time to time of being dull people, one might not even notice this inflammatory cell. But again, there are plasma cells distributed and scattered through that blood vessel, making us alert to something going on. Now, if we stain this for organisms, you notice in this particular erythema migrans, there is not very much inflammation. This is a silver stain that we call a modified Dieterle stain that takes us about 12 minutes to do now in a microwave oven, the very same that you have in your kitchen counters. And here we have the organism sitting right into the collagen, and it tends to be around collagen. It likes collagen for reasons that we don't have time to go into this morning. Now here's a case of erythema migrans, and this is what happens. The organism leaves the collagen of the skin and enters the bloodstream, as you can see right here, and that one's about to depart and move for places wherever. But that's how it moves around. Now an interesting thing this summer, we had a sergeant in the Army Reserve. Well, he's a sergeant now. He wasn't when he did this test. But he would have made sergeant anyway. But he approached me and wanted to know if I had ever used an ordinary blood film stain that you can get done in any shopping center in 10 minutes with $6 to stain the organism. And I said, no, I'd never done that. And he said, mind if I try? And I said, well, sure, as long as you keep doing your other jobs. He was a Jeep driver. He no longer is. We're now sending him to school. This is what he did at the end of June this summer. He took a blood film stain and found that he could stain the organisms in the blood. So in other words, we have a 5-minute stain. He's going to publish this too, although he doesn't know it. But we can take this blood film stain that I call the Andy Splitz Rapid Stats stain and see if we can actually demonstrate the organisms in experimental animal models. So we're quite proud of that. Now let's move into what happens in the early going. This is when people get the infection within a period of weeks. You've heard all the past day and a half that people have flu-like symptoms, and indeed they do. And basically think of it as a viral-like illness with fever, weakness, marked weakness, and the weakness stands out as a strong effect, accompanied by even sore throat, chest pains, feeling terrible like you don't want to get out of bed. And you may have objective findings of swollen lymph nodes, splenomegaly, and at times even hepatitis, although we've not ever seen jaundice. And of course, men can have swollen testicles, although not to the point of having mumps, but they can be tender. There may be some blood in the urine. The urine may look a little cloudy, and something that does not seem to be interrelated. It truly looks like a diffuse infectious syndrome. Pathologically, and this is that lady that died from Pittsburgh that Dr. Lavoie had quoted, and this is her lymph nodes, and you can see that there's a tremendous response of plasma cells growing out of the lymph nodes, and in the middle was this particularly transformed looking plasma cell, that is to say a plasma cell in an early stage, not a stem cell, but a plasmablast type of cell, and once you see these, in fact, it looks like a lymphoma cell that we call a Reed-Sternberg cell. There begins to be plenty of those floating around to the point where we could almost think of an early tumor stage. So you had organisms loaded in there, and then you can see how profound these cells are distributed throughout. Very profound reactive. And we find that these cells are actually engaged in making antibody. And since she had her illness in the first stage, she was making IgM. Later on, she would make IgG had she survived. So you can see that, and this is a special antibody stain for that particular immunoglobulin, which is IgM. Now, this is another patient from Yale, actually, sent to me. I see more consults from Yale living in Philadelphia than when I was at Yale, but this is a case of a woman with swollen lymph nodes in the early stage, and this was the first time we've ever seen the lymph nodes showing necrosis. That is, here's an area of actual necrosis and breakdown of cells. She had antibiotic therapy and resolved. Now, this is a patient who died in Europe from Lyme disease, and the spleen in this particular patient has the same large, abnormal, atypical appearing plasma-like cells being grown within the spleen. And if we look at that particular patient, we can see that there are organisms growing right in here. They're extracellular. They're not in the cells themselves. They're out in the interstitium. And this is a very, very interesting case from Hartford, which is now in press and literature. This is a drug user who entered the hospital with a rapid enlarging spleen, which then began to rupture, so he became a surgical case in the middle of the night. And the pathologist was suspicious, and I'm glad, because in addition to this necrosis that you see here of this spleen, there were multiple organisms, and some of the most classic appearing organisms within that man's spleen. He recovered after antibiotic therapy. This is one of the best examples that I have in my collection of the typical morphology of the spirochete. And I'll leave it for a second or two, of the spirochete as it sits in tissue in an extracellular form. So we know that the organism occupies an extracellular position. This is an example of hepatitis. The hepatitis, of course, is not as severe and fulminant as you'd see in viral hepatitis, but it is hepatitis nevertheless, and patients will have abnormal liver function tests, although they're not to the extent that you would expect to see in viral hepatitis. But again, it's a hepatitis nevertheless. And again, there are plasma cells occurring in this effect. Now, also acutely and very strangely, more likely in Europe than we would see here, although we do see it here, is a situation that we call lymphocytoma borreliosis, and that is a term that applies to a redness and swelling of soft tissues, usually of the ear and of the neck, but also the breast and the nipple and around the axilla. It's very peculiar, And if one biopsies that, we see a proliferation of lymphocytes to the point where it would look like tonsillar or appendiceal tissue occurring in the skin. And we have a lot of terms for that, but we now know that the organism is directly present there. It's actively growing. It can be cultured and isolated from such a lesion. Very peculiar, but it's not very common. Once it occurs in stage 1, it will persist for years unless the patient gets treated. Now, later on, if the disease continues on without spontaneous resolution, and that occurs, and I'm sure you're aware of that in some patients, if spontaneous resolution doesn't occur, or if the patient is not diagnosed and treated, they may go on to have heart involvement. Now, that can occur in a period of weeks, several weeks after the point of infection. As it does so, it may also involve the central nervous system, and not necessarily in a chronic way, but in an acute way, complete with encephalitis-like signs and symptoms. Now let's take a look at that pathology. This is somewhat of a dark area because a lot of people don't like to break this down into stages, and I'm not presenting that as a point of argument, but it's a way of looking at the disease acutely and chronically. So we had to darken the shadow on this stage. But if we look at this, we see real anatomy. This is a biopsy of the right side of the heart done simply by passing a catheter through the popliteal vein, a very benign procedure in good hands. Emphasis. And this man was treated in Yale, recovered, and what you see here is a myocarditis of plasma cells and lymphocytes going in and out of the muscle, and a very interesting band of cells.
And there goes, thank you, Jose. There's a television set in here that is seeing
heart transplant pathology.
Dave Dawson must watch it, Rush Limbaugh watches it. I'm the only one who has a concentration level that precludes my having it set.
On just the basis of a standard routine H&E, $25 H&E stain, we can be suspicious that it's Lyme disease. Here you see it close up. We made the diagnosis. He got penicillin and went home without the heart involvement that he came in the hospital with. Now this is a man from Cape Cod who wasn't diagnosed and went on to die. And you can see in his heart at autopsy, again, there are more lymphocytes and plasma cells out in the endocardium, just like in that last case, than there is inside. Importantly also, around the vessels inside the myocardium are immune cells more or less attacking the vessel. We call that a vasculopathy or an inflammatory effect that's using the vessel itself as a target, as opposed to just going after the organism. Now that was cardiac. If we look at central nervous system in this sort of intermediate stage of infection, this is spinal fluid from a patient that had a spinal fluid test, and there are so many cells here that one could actually wonder about lymphoma or leukemia involving the central nervous system, and that's not uncommon for various types of leukemia and lymphoma. In fact, the cells almost look abnormal. If you will recall, those abnormal cells in the lymph glands, lymph nodes, and spleen of other cases, you can see the same kinds of cells. So we know that the spirochete, its proteins, its antigens, are turning on the immune system in a very interesting way. Now, this patient did not make it. I don't want to imply that this is a lethal disease, but of course my collection generally comes from that kind of situation. This is a patient from Europe, and this is a section of brain at autopsy. There's some inflammation here, but the biggest inflammation is across the brain covering, the meningeal layer. So that patient did have meningitis, and now you can understand why they have, when patients have this phase, that they have cells spilling off into the spinal fluid. Again, a band-like lymphocyte and plasma cell layer across the meninges, giving you what amounts to classic meningitis. Another case we saw was one of a gliosis, that is, the small microglial cells of the central nervous system that have macrophage function and all the effector cell function and macrophages have, were also found by biofunction of these cells in the brain, again targeting the vessels. And this is a happy case because this is a brain biopsy that we did on a man at Yale who entered the hospital with profound, bizarre clinical history that I don't have time for, but in biopsy he had microgliosis nodules proliferating even in very small pieces of a brain biopsy, had organisms in the central nervous system. He was in coma when the biopsy was done, and after he was treated with intravenous therapy very intensely for I forget how many days, he woke up and left the hospital. Didn't pay his bill either. But anyway, this is not such a happy case. This is, you heard about some of the visual and retinitis situations. We're beginning to now hear a little more about that from the ophthalmologist. This is a younger woman from the West Chester area who had Lyme disease for approximately 4 weeks, and she lost vision in one eye because of necrotizing retinitis, and she had organisms still growing in her retina when she had treatment for that. She did eventually do well, though. Now, something we've just recently appreciated in the last 2 years is that patients about the 4th week of infection, but then may persist on for several months, may have pain and may even indeed have swelling of one of the proximal muscles, such as the thigh, the forearm, the scapula, and muscles like that. We now know that there is a myositis, and this is a picture of Lyme myositis. It doesn't look unlike that of dermatomyositis or polymyositis. Organisms are present, and they've actually been isolated in one patient. So we can add that to our list. This is a German case with myositis. Notice the inflammatory cells not destroying the muscle bundle, but forcing in and out, and yes, those are plasma cells. So we can add myositis. Now, if we go on to the chronic stage, and that is when patients have infection for years, and we know that they can have infection. The longest I know of was infection for 28 years, and there are two things that especially happen if you have Lyme disease for years, and it begins to affect the central nervous system and the peripheral nervous system. In other words, the peripheral nerves that feed into the limbs, the arms, and like become affected, and then finally the organism, as it's coming back to that collagen into the skin, comes back and produces a ever-expanding and growing list of dermatologic syndrome. We'll kind of deal with each one of these. They all have foreign names that none of us in medicine have liked because we've had to learn these Latinized names that dermatologists give to these situations. Things like lichen sclerosis, granuloma annulare, scleroderma-like conditions, morphea, vasculitis, Schulman's-like disease, ulnar fibrous subcutaneous nodules, and so on and so on. The list goes on. We're beginning to appreciate that many of these things are actually due to Lyme disease. The one major thing that, and this is probably the most photographed, widely circulated pair of legs in the United States today because everyone seems to have this slide. I don't know who this gentleman is, but he's more popular than Mae West ever was. But he has clear-cut classic arthritis, and if we look at the pathology of that, this is an X-ray of someone with very profound Lyme arthritis. It can almost look like a bone tumor in the exoskeletal spaces. If we look at that, and we have, of course, seen the organisms in the synovial fluid, as you can see here, there's a phase contrast photograph. We see in some cases that there are marked deposits of fibrinogen and fibrin occurring within the synovium itself. There's only two other diseases that'll do that. One is just plain hemophilia, where you have a lot of deposits of fibrinogen within the joints. And the second one, I believe, is Lyme disease. Now, you can have small portions of fibrinogen in Reiter's disease and rheumatoid arthritis, but not to the extent that we see it in hemophilia and in Lyme arthritis. Now, the vessels are damaged in the synovium in a very interesting way. I photographed this before the discovery of the spirochetes in 1982. And at that time, I remember telling Alan Steer that the vessels in Lyme arthritis remind me of the vessels, and this is an onion skin vessel, that occurs in syphilis. A few months later, Willie was able to find the spirochetes, so things began to make sense. This is one of the first spirochetes we saw in Lyme arthritis. We saw this in December of 1983. I'll never forget it. It was 10 o'clock at night and went running down the hall and tripped. Now, this has been a tough road to hoe, telling people that there are bugs in the joints in this disease. And finally this month, Dr. Schmidli at the University of Bern in Switzerland finally cultured a spirochete from a joint from a patient with Lyme arthritis, 15-and-a-half-year-old girl. And thanks to him. So that has finally been borne out. I think we'll just skip that. That's just comparing all the joint effects. Now, problems with nervous system are very profound, and you've heard about some of them. This is a whole mount of a ganglion, sympathetic ganglion in the neck. This is what's called sweating, and it does all of the sympathetic functions. And the autonomic nervous system, this is part of the nerve coming out. These are the sympathetic neurons, they're very large cells. If we look closer at higher power from a Lyme disease patient, we can see that the inflammatory infiltrate is actually causing dissolution and damage to individual ganglion cells. And those cells are responsible for conducting nerve impulses, fine-tuning the system, and if they're disappearing, the system is not going to be very fine-tuned. Hence, you have numbness and tingling and dysfunction and all of the dysautonomia syndromes. Now we know why. This is a serial nerve biopsy in a patient with peripheral neuropathy who had the disease for over 6 years, and you literally would drag the left limb around. This is the serial nerve. You can see the lymphocytic, plasmacytic infiltrate. And this is a case from Switzerland of neuropathy. There are two things here. This is a myelin stain cut at 1 micron thick, so that you can see some pale. You can see that the myelin is the blue color protein material that covers the nerve conduct directly. In this particular patient with Lyme neuritis, the myelin is actually disappearing, and there are again plasma cells targeting that vessel of an interesting degree. Now, as we go into the skin in the late stages, we begin to see, and as I warned you, we begin to see a whole plethora of syndromes that affects chronically with varying a lot of names. This is the classic hallmark of chronic Lyme disease involving the skin. We call acrodermatitis chronica atrophican. It occurs in older patients, but not because they're old. It just simply occurs because they've had the disease a long time. But you know, and I know, that you see a lot of people that have this kind of purpura around for a long period of time, and it just so happens this one is caused by Borrelia burgdorferi, and yes, you can culture the spirochetes from that lesion. If the lesion had been there 12, 14 years, and I think Dr. Osbrink says the oldest one they have in Sweden is older than 12 years, and they were still able to isolate organisms. Here's another symmetrical appearance of ACA, or acrodermatitis chronica atrophicaans. It usually is symmetrical, tends to be symmetrical. Involves one side, it will do the other, and it usually involves the distal part. That's why it's called acro, meaning distal dermatitis. An unwary dermatologist might consider that that's psoriasis or some other type of illness. Now, this is one of Alan Spear's younger cases with ACA, and you can see on the extremity. The photograph really doesn't do justice. The erythema is marked here, running along the outer edge of this limb, but also in this area here. And this one is beginning to be involved as well. If we biopsy that, and it showed typical pathology. This is typical pathology for acrodermatitis. And we lose the reed ridges, the epidermis. The top part of the skin shows a thick keratin scale, and the dermis is filled with inflammatory infiltrate, unlike the early stage of erythema migrans that I showed you, where the inflammatory cells were clustering around the vessels. Another effect that it does, strangely, is to leave the vessels in somewhat of a telangiectatic, dilated portion like that. Very characteristic when we see that. More common in Europe than here is the condition called ulnar fibrous nodule. These are little rubbery deposits occurring around the elbows. It may look like gout, it may look like rheumatoid arthritis, and of course it has to be distinguished from that, and this is where pathologists can help if they know about the disease. And this is one of these rubbery nodules removed. They usually occur in patients with acrodermatitis chronica atrophicaans, so it is a chronic form of Lyme borreliosis. And what we see pathologically is amorphic collagen in a very strange combination with plasma cells and activated macrophages. It's more about the macrophages in the spring when we finish the aesthetics on them. But plasma cells are still growing, even in a collagen that looks very old and worn out. Now, patients that here's such a vessel and an ulnar fibrous nodule. The vessel has been obliterated. Plasma cells and macrophages are still around, and the skin overlying that ulnar fibrous nodule in this particular patient had active spirochetes. Well, in case let's have the lights, in case we don't make it through. After you leave the stage, there are a number of other skin syndromes that we could see after the ulnar fibrous nodule. One is the lichen sclerosis, and the clinicians in the audience are very familiar with lichen sclerosis because it occurs around the vulva, around the thighs, and sometimes the shoulders and the axillary skin. We know that there are a number of patients who develop lichen sclerosis in the course of their disease with borreliosis. Another one is granulomannulari. There are a number of cases in Dr. Berger on Long Island, a number of them in Philadelphia, and also in Europe have found that granulomannulari can be a form of Lyme disease in skin chronically. Another form that we saw recently was a scleroderma-type lesion that Dr. Mersick had isolated organisms in Germany from, and that we were able to demonstrate organisms also in our laboratory in Philadelphia. Another picture, the next picture shows.
Does anybody have any tweezers? Tick tweezers or anything?
That's all right, it's not working.
They go in here.
Take this off, twist this.
I was going to, then that would have completed the skin slides. The next group of slides would show you an active infection from a mother who developed her infection about the 5th week of pregnancy, and the baby did not die in this particular circumstance. We were able to get the placenta, and this is one of the few stains, sometimes where we did actually
Take it off.
Do fluorescence. And see, I told you.
Where's the top? Oh, no.
And in that particular circumstance, there were spirochetes present, and those were the last pictures. The last two pictures were just simply a culture photograph comparing Borrelia burgdorferi with Treponema pallidum, which is growing in colonies. And that was an important slide to end up with, because that is the thing we have to remember, that Treponema pallidum, the causative spirochete of syphilis, grows in colonies in tissues. Borrelia burgdorferi grows in colonies in ticks, and in the laboratory in test tubes, but does not grow colonies in human beings. And that is one of the reasons the organism presents in such a strange fashion. Its pathogenesis is odd. Its diagnosis is difficult and elusive. And it's hard for a pathologist to be convinced that the spirochete can cause any sort of pathologic derangement because you can't demonstrate it in colony formation. That is the single most problem for all of us in the laboratory. And it reflects the pathobiology, because instead of the body walling off the organism in a very localized way, as occurs in tuberculosis or staph, carbuncles, or whatever organism you want to name, this organism floats through the body in a very diffuse, leisurely, laggardly, lazy manner, and it just attempts, it teases the immune system. All of that, it teases the immune system, so that the immune system is not responding in a very raging fashion, but in a very indolent, but subtly destructive way. And that is, in my way of thinking, is part of the reason why we see such a plethora of laggard clinical syndromes that look like a lot of other things and make it very difficult to diagnose. And I think that there are many molecular reasons why the serologic responses in this disease are the way that they are, as opposed to looking at syphilis. So the pathology has taught that to us over this past 6 or 7 years, that this infection is a diffuse, somewhat of a leisure situation. The organism just winds up in various sites. I think there are some good pathologic reasons, biologic reasons, why the organism gravitates towards nerves, brain, collagen. The rest of the stops that it seems to make on its tour are probably accidental, unintended, and just chancy. But the immune system is doing something at the cell level, at the molecular level, that once we crack this, and I'm not going to do it, a lot of brighter people than me are going to do it, we're going to understand a lot of other things too. And I think we're going to understand how breast cancer antigens are handled in some patients and other types of diseases as well. And perhaps we'll understand the whole kit and caboodle that we call rheumatic and collagen vascular. I'll open it up now and I'll quit.
I wonder if you could comment on your feelings based on your experience on the entity of seronegative latent Lyme disease from your viewpoint.
Well, it would just be that, just a personal opinion, since I'm not an immunologist, and there are better people who could answer that question. I'll give you one theory that I think makes some sense. The organism, and I warned you, we weren't going to talk about the pathobiology this morning, but the organism makes proteins that we call outer surface membrane proteins, or OSPA and OSB. These are just designated by Alan Barber based on their molecular weight. We now know, particularly from our colleagues in Europe, that outer surface membrane protein is irregularly presented to the immune system. By that I mean, once infection takes place, that protein may not be in very high amounts, but another protein may be. I did not bring pictures of the gel electrophoresis of the whole protein complement of this organism. There are now 47 proteins that we know of, and some of these proteins have a very high molecular weight, that is up to 90 and up to 100,000 molecular weight. Some of those proteins are very important in antigen recognition by our immune system. Other of those proteins are actually found in widespread places in nature, and it's also been found in cancer cells. We call those highly conserved proteins, and they're there because of the presence of highly conserved genes. So the organism is, I hate to say it, a little bit like a mammalian cell. It seems to have a lot of genetic machinery and protein making capability, which is variable. That's what the word Borrelia means, something that varies. So at any given point in time, if an organism only doubles every 24 hours, and in the microbial world, that is a dull bug. That's a very slow bug in terms of doubling time, 24 hours. And I think that and those are laboratory conditions. In the mammalian system, it could be, the doubling time could be 6 weeks. So there's lots of opportunity to change the protein network that's presented to you and me. If you don't present antigen to us, we won't mount a response. Or if we do, it's also a lazy response. See? But then there also may be reasons why patients may respond in different ways based on their own HLA or B cell haplotype. And I think that is a system that should be dug up again out of the woodwork and taken a look at. But it was looked at for time, but these labs are not funded, so no one's going to be able to do that kind of work. So I think there are a lot of reasons why we see this drop in serum. And the other thing is that some patients may not just simply recognize that particular protein. It may not be that much of an immunogenic protein. In the laboratory, it appears to be, but in a mammalian or high mammalian system such as humans, it may not be. And look at the situation with schistosomiasis. We know that schistosome eggs, once they get into the liver, begin to elaborate an HLA-DR that looks just like our own macrophage HLA-DR. So once that happens, you have now a camouflage, if you will, around the real protein, so that there won't be immune recognition of that outer surface protein. So there are a lot of neat little things that could be happening, and I think that one of them is going to be right. Exactly which one, I don't know if I answered.
I think that the basic question is how credible one can feel and how confident one can
I never feel credible.
in making a diagnosis of Lyme disease in a patient who has a plausible clinical syndrome with many clinical circumstances that support the diagnosis. However, it's in what would presumably be a late stage, and you cannot prove it serologically.
Surely. Well, I still think it's fun to be in medicine. I really do. And I think that is the sense of being a practitioner. And it's drawn on experience. As you know, with the CAT scan and enzyme tests and any molecular test, the ultimate diagnosis of many things still rests in the office, doesn't it? And I think that you do make this diagnosis and assessment and your final judgment based on all the evidence that you have, which begins and I think ends in front of the patient in the office. So I still say, and I would mimic the wise words of Alan Steer, the diagnosis, as we stand here, should be rendered clinically. Now, we have some neat and fancy stuff, but it's not going to make the ultimate diagnosis. I still think you have to do that and then treat the patient accordingly. I think we have to be careful and not call everything Lyme disease. You know, we've been saying that Lyme disease mimics a lot of other things. Well, a lot of other things mimic Lyme disease, too. You could say it that way. Because people still do have flu and rheumatoid arthritis and depression from other reasons. That's a very good question.
Thank you.
Yes, sir.
In the endocarditis, do you see organisms there, and would that have implications in terms of long-term treatment necessity?
Yes, you do have organisms in the heart, and I'm glad you brought that up. I think we're going to miss lunch, but I hope not. I'm glad you brought that up. The heart involvement, it looks frightening, it looks stunning, and certainly it is pathologically, but for reasons I don't understand at the physiologic level, I promise I won't do this, I don't want to speak, but it's very transient, and there is evidence that patients probably have spontaneous resolution of myocarditis. Now, occasionally, it isn't, because that's when we get the opportunity to see it. Now, with that amount of pathology in the heart, you and I wouldn't care to have that. It appears that this is transient and almost spontaneously resolving, so that the organisms are there, but they seem to be there for a very brief time, and maybe that's the reason that there is spontaneous resolution. There is maximal inflammatory cell response. So perhaps, if you want to think of it that way, cause and effect, that amount of inflammation will take care of the organism. I just don't think you and I would want to gamble. If you can document myocarditis clinically, and you can, because the patient will have tachycardia, and an electrocardiogram will have a bit of an idioventricular rhythm disruption at the junction that a good EKG reader will find in the presence of tachycardia. And the block, and there usually is some sort of block. It may vary from incomplete all the way to a complete AV block on electrocardiogram. Will be a little bit varying, and that's the clue. It's an irregular block. That's the clue that the EKG reader is looking at Lyme myocarditis. So if you can make the diagnosis, I would treat the patient. But it appears that cardiovascular disease is not chronic. It does not go on. Again, it's an intriguing question. It's why the organisms are there and don't remain chronically as they do, say, in the skin or nerves or joints.
Or one more.
One more. Uno más. Yes, ma'am.
On an X-ray, can you tell the difference between Lyme arthritis and ordinary arthritis?
I can't. But yeah, yes, ma'am, there are some subtle changes. In rheumatoid arthritis, there are things that the radiologists can see, and rheumatologists can see and describe as pannus formation that's best developed in rheumatoid arthritis radiologically than in Lyme. There are some changes like that, but there are some similarities to it. But a good reader can tell them apart ordinarily. For example, we don't see, for example, the subluxation of joints that one can see, the ulnar joints and so forth of the hands that you've seen people with rheumatoid. We've never seen that in Lyme.
But why I was wondering is sometimes the Lyme, you can help with drugs or whatever. Would that cure Lyme arthritis from knees or arms or joints?
I think I know what you're saying, but I'm not.
Operation where the ordinary arthritis, you have to have an operation.
I think I know what you're getting at, but
Yeah, and I can't put it in words that I like. I had 2 knee replacements, and I'm just wondering, if it had been Lyme arthritis, could I have avoided having them by drugs or something or other?
That's hard. I kind of doubt it, because if you have Lyme arthritis, first of all, Lyme arthritis usually doesn't destroy a joint. And if you had to have your joints replaced, I'm sure they were destroyed.
Well, I never had pain in them. It was just like somebody twisting my knees over the
Yeah, yeah. I'm sure that they were destroyed. And in Lyme arthritis, you usually don't get that amount of joint destruction. It's mostly a soft tissue erosion. It's mostly soft tissue, but not that frozen joint that you made. I don't think you had Lyme arthritis.
Well, that's what they say. I had 2 hip replacements, and I had no trouble with my knees. And a few months after, the others started.
Thank you.
Okay, before the next speaker, Karen has another presentation.
This is the last presentation. What I'd like to do is really a little reason what we're doing with this. In the solution for Lyme disease, it's going to come from a number of areas, not just the medical community. It's going to come from the legislators getting research money and legislation going on it. It's going to come from the health departments that are working overtime to help solve the problem in the areas that are heavily hit, the hyper-endemic areas. It's going to come from individuals who are pushing for the rights of people who have it, for funding for those that need to do the research. It's also going to come from the corporations who are showing corporate responsibility in helping their employees in their community avoid the disease. Throughout the United States, we have seen one outstanding example of leadership in corporate responsibility in protecting their community, and it has been Ciba-Geigy. Ciba-Geigy is a leading developer and manufacturer of agricultural, chemicals, pharmaceuticals, dyes, plastics, vision care products, and specialty chemicals in the United States. One of the things you notice it does not have is antibiotics. The motivation to help protect their employees is an inward motivation. We have asked Richard Barth here today, who is President and Chief Executive Officer of Ciba-Geigy, to come. Wait. We'll give a quick, I happen to have his resume just faxed in. I've asked him to give a quick little 5-minute speech. His agenda has been full at the company, so he has made time to come so that we could present it and give him our thanks. He began his career in 1957 as a lawyer and joined Ciba-Geigy, at the time, in 1965. He moved up the ranks and was named General Counsel, then Corporate Secretary. In 1975, when Polly Murray was busy in Lyme, Connecticut, he became a Board of Director member. In 1979, he was General Counsel and Corporate Secretary and elected Chief Financial Officer and Chairman of the Board's Finance Committee. He served as Senior Vice President of the corporation and then moved up to President and Chief Executive Officer. He is also a member of the Board of Directors of Irving Bank Corporation, and he serves on the Board of Trustees of Wesleyan University. He has worked hand in hand with the health department, the press, and the people, offering his corporation's facilities for public speeches, for speeches to his employees on a regular basis, and helped Westchester and Betty Gross and a number of the people in the area to alert the people in Westchester to Lyme disease. So for that effort, consistently, year after year, when most corporations across the United States had not yet taken up the banner of corporate social responsibility to include Lyme borreliosis, we would like to hold him out as the standard for which everyone else should measure up to. We'd like to present to him what it says on the plaque is honors to Richard Barth, President, Chief Executive Officer of Ciba-Geigy, for outstanding corporate excellence in protecting their employees and their community. And now you'd like to do your speech.
I thank Karen on behalf of Ciba-Geigy for the recognition. The company has a self-interest in supporting the efforts of the foundation in bringing to everybody's attention the serious situation that Lyme disease presents. In the county, we're one of the larger employers. We have 1,500 people. Many of them live here in the county with their families, and so we do have a self-interest in making sure that our people in our company are conscious of the risks of the disease. Then Karen and the foundation brought to our attention that there was a broader need in the county to get the word out, to make people sensitive to that. And so with the county executive, we lent our hand. We're in the drug business, pharmaceuticals business, and so we know the difficulties of coming up with solutions to this type of a condition. It takes a lot of time in our business. It takes 10 years to develop a new pharmaceutical, and it takes a lot of money. And between the time of working on the effort to find solutions and cures to disease, a lot of people, unfortunately, are afflicted with those conditions. And clearly the best way to deal with that in the interim is to spread the word and see that prevention is possible. And so we've gotten on the bandwagon, and I'm pleased to be participating and leading in that effort, at least in the county here, as a corporate member of the community. Let me just wrap up by saying I do think really the people who should be honored are not the corporation, a corporation such as ours, but really the volunteers who are making the effort to get this mission moving, and the results of that is clearly the response that your program has generated today. Without that volunteer effort by the people in the foundation, Karen, none of this would happen. We were participants who picked up and joined along the way, but I'd like to just wrap up by saying really we're a small player in this effort, and those volunteers who take out of their time, personal time and effort to make this happen, I'd like to express our thanks to them. Thank you very much.
Okay, now we shift gears a little bit, and we'll go into the veterinary realm for the next several talks. The next speaker is Dr. Betty Burgess for the University of Wisconsin, who has been involved with both the ecological aspects and small and large animal aspects in the veterinary practice for the last several years. What she will do is give us the basics of clinical Lyme disease in domestic animals.
Since this map has been done, we know that it is in Michigan, Indiana, Illinois, Iowa, and we have found positive horses in British Columbia, Canada, and in Ontario, Canada. So it has spread. It is in Canada now, and it has spread significantly throughout the United States in domestic animals along with humans. We all know that the major route of transmission is by Ixodes damini. But I think what is important is that what we're seeing in the animals
seasonally is a little different than what you see in humans. And this gives you an indication of when the nymphs are out, and it's in the early summer, May, June, July, and this is when the majority of the cases of human disease occurs is in June and July, because it's primarily the nymphal stages of the tick that are feeding on humans. This is somewhat different than what we see in the animals, because in the majority of the domestic animals, it's the adult stage of the tick that feeds on them. And the adult stage is present early in the spring, April, May, and then it reemerges again in the fall, October, November, and December. So you see a little different pattern of the disease in animals. Now this is from Wisconsin, and you must realize that the tick season varies throughout the country. We have a different climate than you have in New England, so this is what we're seeing in Wisconsin. These are antibody-positive animals, and you can see there's a peak in November and another peak in May and June. And this has been going on the past couple years, is that we'll see two peaks when the majority of cases occur, and this is spring and fall, correlates with when the adult tick season is. This is the same with the cats and the horses and the cows. So the cows are a little bit different. I'll go into them later. They don't have quite the seasonal incidence that the others do. Disease can occur anytime during the year. It isn't limited to spring and fall, but that's when the majority of the cases occur. Not only is it transmitted by ticks in animals, but contact transmission becomes important in animals because of the way animals, their behavior and their interactions. It's spread through the urine. We found it isolated in the urine of dogs and horses and cattle, and contact transmission is a viable route in these species. Depending on the species and the interaction, how important this becomes varies, and when we get into dairy cattle, it becomes quite important. We have seen actual infection and disease in cats, dogs, horses, and cattle. The disease in dogs and cats is pretty similar. This is a dog that actually does have Lyme disease. He's not a pointer, he's a Great Dane, and he's holding his leg up because it hurts. And this is actually the first dog I ever saw with Lyme disease. And this dog was in acute pain, and there's nothing you could find wrong with the leg. It hurt, but there was no one spot that hurt. There was no history of trauma. There was no injury present. And the next day he came in holding up his left hind leg doing the same thing. And this seems to be one of the common signs that you'll see in dogs. There may be a fever early on, and this can be normal in a dog is around 101. The fever can be as high as 104. Correlating with a fever is they don't want to eat. The most pronounced thing is the sudden onset of lameness. There's a very acute onset of lameness and pain, and there's significant pain. It's unusual for a dog to cry out in pain, generally, particularly that dog, and he was crying in pain. And there's no history of trauma, no particular reason that you can find for the pain. Joint swelling may or may not occur. We don't see it that frequently. I think maybe in New England you see it a little more frequently. It may occur. We have seen lymphadenopathy in some dogs. This can occur primarily in the prescapular lymph nodes and the popliteal lymph nodes. I think those are one of the some that are easiest to feel and easiest to notice when they're enlarged. We have not seen the skin lesion. I know that some people have. We just have not seen it very frequently. I think in the animals it's difficult to see because they are covered with hair, and I don't think it occurs that frequently in animals, but it can occur. It's hard to estimate the percentage, but maybe 1% of the cases we have seen myocarditis and glomerulonephritis, and these are the two cases where this disease can become fatal in animals. In most of the cases it is not a fatal disease, but when it does become fatal, it's because of the myocarditis or the glomerulonephritis. It can lead to chronic arthritis if it's untreated, and this takes several months to develop. I'm not a pathologist, and I hope Dr. DeRay doesn't get embarrassed by my slides, but this is our one dog with myocarditis, and as he said, we saw massive infiltrations of lymphocytes and plasma cells into the cardiac muscle, and this dog was presented in acute heart failure and died within a couple days before we could even begin to do anything for it. And as you can see, I don't think treatment would have probably been very successful. We don't know how many of these have mild myocarditis that goes undiagnosed. The ones we have seen, by the time they get to us, are very, very advanced and beyond any helpful treatment. We've seen the glomerulonephritis, and again, this was generally has a fatal outcome when it gets to the point where you can recognize that they're having kidney disease. When it gets to the point where it's recognizable, it's very difficult to treat. Lyme disease in horses is occurring. It has some similar presentations as to what you see in the dog, and it has a few differences in that horses are a little different creature and are built a little different. Just to show you, this is a tick, where the ticks like to feed on horses. They'll feed anywhere, but they like the tail, and oftentimes you'll find them only on the tail. And this is a dermacenter, but you can see it attached right there. And oftentimes you have to feel for these ticks, and on the dogs also. You can't see them readily sometimes, and if you feel, you can find them. And if you take, these are right on down on the base of the tail, so you need to take and just feel along the base of the tail. If you can't feel the tick itself, you can often feel where it's been, because you'll see this crusty serum exudate, and you can feel that. And this is what it looks like. This is on the back, it's not on the tail, but this is what it looks like after the tick is gone. So even though you don't see the tick, if you find areas that look like this, you know the tick has been there. Signs in the horses, again, include lameness. This is probably, again, the most common sign. Unfortunately, there are many, many causes of lameness in horses. Much more so than, there are many causes of lameness in dogs, but in horses it's even multiplied. So it becomes difficult to determine if the lameness is due to Lyme disease or some other problem. And oftentimes it's a combination of things. Things don't occur in the real world all by themselves. And Lyme disease is often found in association with other problems. And in horses, arthritis is a common problem, and it's given all kinds of neat names like ringbone and navicular, but it's basically arthritis. And horses that have these common problems, ringbone and navicular, often will get Lyme disease on top of it. And the owners can pick it up, because if you have a horse that's had chronic navicular disease, you kind of know what kind of lameness it has. And all of a sudden it'll get much worse. And the owner will say, my horse's lameness has gotten much worse, and usually the veterinarian will say, well, it's got navicular, what do you expect? But if you really look at it, we have found several of these have actually had Lyme disease, and when treated, it will go back to its, quote, normal lameness. So that it becomes very subtle, but you can see differences. There may, again, be associated swelling of the joints. There may be swelling of the tendon sheaths in the horses. There may be generalized stiffness. You have the muscle, the myositis, be stiff throughout their body. Often it's the rear end that is stiff. Again, they may run a fever early on. The fever usually is only for a few days, and then that will go away. They will develop arthritis more frequently than the dogs do. So you will see actual arthritis in the horses, again, more frequently than you will in the dogs. Again, it takes a while to develop. It doesn't develop in the first week. It takes probably several months for the actual arthritis to develop. Weight loss. We've seen chronic weight loss as a sign of Lyme disease in horses, where they will have a chronic weight loss over a several-month period with no explanation. In horses, oftentimes it's the teeth, it's worms, poor feed. If you can eliminate these other items, their teeth are all right, they have a good worming program, and a good feeding program, they're eating, but they're losing weight. To start considering Lyme disease. We have seen encephalitis in a couple horses and reproductive problems. This is, oftentimes the arthritis will be in the carpal joints or the knee joint of the horse here on the front leg, and you will see a distended, swollen knee. We have seen anterior uveitis, and anterior uveitis is a problem that horses tend to develop more frequently than other species. It's common sequelae to leptospirosis infection in horses, and we are now also seeing it in association with Lyme disease. We actually isolated the spirochete from the anterior chamber of this horse's eye, and this horse did have Lyme disease. It had high antibody titer, it had arthritis, it had kidney disease, it had the full systemic disease, but amongst them it did have anterior uveitis. We have seen several other horses since that the only sign they had was anterior uveitis. It becomes a bit of a diagnostic problem in that it's difficult if they have antibodies to Lyme disease and they have anterior uveitis to say there's a cause and effect every time. Some of these animals will also have antibodies to leptospirosis and Lyme, which makes it even more difficult because, as I mentioned, leptospirosis can also cause anterior uveitis. So diagnosis can be a very difficult problem in some of these cases, but it is something to consider. Arthritis, this is from that same pony with the anterior uveitis. It had proliferation of the synovium, it had increased synovial fluid, and it did have actual arthritis also. This is just the proliferating synovium, and apparently looks very similar to what you see in the human disease. This is to remind me that we do have reproductive problems in the animals that can be attributed to infection with Borrelia burgdorferi. We had followed a breeding herd of horses. Out of 7 mares in 1 year, they had 5 dead foals. They had 1 live foal that lived to be an adult, and 1 foal that died as a yearling due to Lyme disease. These foals, the first 5, died during the first day or 2 of birth. They'd be born, they'd be very weak, they'd be unable to stand and nurse. They had they did have antibody titers to Lyme. We were able to isolate the spirochetes from the kidneys and the lungs of these foals, and they did have kidney disease. They had nephritis, and we were also able to show spirochetes in the kidney tissues, and it was felt that it was the kidney disease that killed the foals. This is the one case that we're able to show died of encephalitis. The owner happened to snap this picture of this horse. It was acting like it had rabies. It was sweating profusely. It was walking aimlessly around the pasture, acting like it was blind. It apparently had a chronic weight loss for several months prior to this, and was beginning to have trouble lifting its hind feet particularly, up over small ledges or obstacles, and was beginning to have some difficulty with moving the hind legs prior to doing this. The veterinarian thought it might have rabies, and for that reason the animal was euthanized. The brain was sent off for checking for rabies. Serum was taken. I got some, and it had 1 to 9,000 titer to Borrelia. It was negative for Eastern and Western equine encephalitis, which are other common causes in this area for encephalitis. The brain was negative for rabies, so I rescued the brain from the rabies lab and cultured it, and did get high numbers of spirochetes, and they were Borrelia burgdorferi, out of the brain of this horse. Unfortunately, we couldn't do anything with the rest of the horse. It had been thrown away, but just based on that, we felt that the encephalitis was most probably caused by Lyme. It was the only thing that we could find. And since the spirochetes were in high numbers in the brain, that's our first case, the indication that it probably can cause encephalitis. This is the kidney of one of those foals that died. They did have glomerulonephritis, and this is glomerulus with a little spirochete sitting right on it. So they were right there in the kidneys. In cattle, it's a very extremely interesting disease in cattle. becomes much more fascinating. The epidemiology of the disease in cattle is extremely fascinating, and it's because of the way dairy cows particularly are housed and how they behave, interact socially. Often they're kept in stanchions like this, and you can see they're on cement, and when they urinate, that urine hits the cement and splashes all over. If they are loose in sheds, which is the other common way of keeping them, when they urinate, oftentimes other cows will go over and actually drink from the urine, and they will actually lick each other's vulvas also, so you get direct contact with fresh urine. We have isolated the spirochete from urine and have shown that infected calf can transmit it to an uninfected calf just by putting them in a room together where there are no arthropods present. And in cattle, this is a very efficient route of transmission. And this is why in cattle the disease is not an individual problem, it's a herd problem. So generally at least 80% of the herd will be infected at a time. You won't go out and find a herd with one cow infected. You'll find most of the cows infected because of this. It is also transplacenally transferred in cattle, so not only can it be maintained through urine transmission, it can be maintained through transplacental transmission. And calves can be born already infected. We don't know for sure if it can cause abortions. Abortions have been associated with cattle that are infected with Lyme disease, but we haven't shown the cause and effect 100% yet. But we do know that you can isolate spirochetes from newborn calves prior to their nursing on colostrum. You can find antibodies in newborn calves prior to their nursing on colostrum. In cattle, there is no transplacental transfer of antibodies. So if a calf is born with antibodies, it had to have been infected in utero and produced its own antibodies. So this means they are being infected in utero. In cattle, the symptoms are similar. Again, you can have a fever, go off feed very early on. They are much more likely to develop swollen joints than any of the other species, and they will have greatly distended joints. And the joint fluid, if you pull some of the joint fluid out, oftentimes it will be a gelatinous material. It will become thickened. And if you let it sit, it'll look like a yellow gelatin sort of. It has an interesting texture to it. They will be lame and stiff. I forgot to mention in horses also you can get laminitis, and in cattle you get laminitis. And because horses and cattle have a hoof over their, essentially over their foot, they can't, if the vessels dilate, if you get inflammation of the vessels, it can't swell because of the bony covering of the hoof. So you get laminitis, you get inflammation in the hoof, and this shows up as extreme lameness and pain. They can also just be generally stiff all over. Abortions, as I mentioned, have been associated with infected cows. We haven't proven the cause and effect relationship yet. Arthritis develops in these cattle. They do develop actual arthritis, and this occurs again more frequently than in some of the other species. A chronic weight loss is also associated with the disease in cattle, and these cattle will again have a chronic weight loss. They'll become what they call downer cows. They'll go down, they quit producing milk, and they're essentially worthless, and these will be shipped. They don't necessarily die outright, but they'll be shipped and sent to slaughter because they're no longer producing, and they're a major economic loss to the farmer. Because it is a herd problem, it becomes much more difficult to attempt to control than the disease in any of the other species. Because, one, the economics of dairy farming, treating an individual cow, if you treat with antibiotics, you have to throw out your milk while you're treating, and you have to throw out your milk for the withdrawal period after you quit treating. It's bad enough if you do this for one cow. If you try and treat a whole herd, it's economically infeasible to do because your losses would be greater than if you didn't do anything in general. So this becomes a major problem in dairy herds because of the cost of treatment and because of the transmission and the way they behave. This just is to remind me that there is transplacental transfer in these species. I have isolated the spirochete from the colostrum of one cow. So it's just, can't tell you much on frequency or prevalence, but we did find it once. We only looked at about 15, so didn't look at a lot. But it means that it can be in the mammary gland. Whether it's present in milk or not, we don't know. Dr. Post has some evidence that perhaps it is in the milk. He's fed milk to cats, and the cats subsequently developed antibodies. So there is a possibility that the spirochetes could be in the milk. This still needs to be further studied. This, again, could be a major, not only could it possibly be a source of infection for humans, but it could be a major economic loss to farmers if milk were refused from infected herds. Diagnosis of Lyme disease in animals is probably even more difficult, or at least as difficult as it is in humans. As Dr. DeRay said, you cannot diagnose it on laboratory findings alone. You need clinical findings, and you need to have a veterinarian who is capable of knowing that indeed there are other problems that can cause similar signs, and that Lyme disease is not the only cause of arthritis in animals, and that there are interactions between Lyme disease and other diseases. It doesn't occur alone in the world. So that you need to take a lot of factors into account. One, serology test is very helpful. It can tell you, one, that the animal's been infected. Unfortunately, as in humans, not every animal that's infected becomes ill. So simply having an antibody titer doesn't tell you that's what's causing the problem that you're seeing. In my laboratory, we call anything with a titer of 1 to 128 or above indication of infection. And I realize this varies tremendously from lab to lab and who's running the tests, so you have to go with what the laboratory says, but in my hands, that's what we've been finding. We have been able to correlate somewhat titers with length of disease, which helps a bit in that if this is a very, very sudden onset of disease, they've had lameness for a week or at the most 2 weeks, we would expect a titer of 1 to 128 or 1 to 256. And if you can correlate the titer with the length of signs, the duration of signs, this sometimes helps you to determine if it is indeed due to Lyme disease. Another thing is a rise in antibody titer is helpful. Unfortunately, if you do not treat the animal and you let it go for 3 weeks to see if there's a rise in antibody titer, if it turns out to be Lyme disease, it's much more difficult to treat at that point. So we've been recommending, if you think it's Lyme disease, to go ahead and treat first. This sometimes will block the antibody response and you won't get a rise in titer, but if the animal gets better, that's our prime interest at that point. And as I say, if we wait, it becomes much more difficult to treat. The sooner we treat the disease, the better the response is, before the spirochetes can disseminate into all the tissue. History is important to know what the clinical signs are, what the history of the animal is. Has it been exposed to an area where there are ticks? Is it exposed to other animals that have Lyme disease? The clinical signs, what are they? Are they compatible with Lyme disease? How long have they been going on? So you can correlate it with the level of the antibody titer. And ruling out, what I don't have up here, which is incredibly important, is ruling out other diseases, or ruling out other causes of the signs that you're seeing. As I said, Lyme disease isn't the only cause of the signs that it can produce, so it's very important to rule out everything else. And then the response to treatment is a good diagnostic tool. If you have an animal that has a sudden onset of lameness, you've radiographed it, you've tested for everything else you can, and it's negative except for Lyme, responds to tetracycline, it's a good bet it was Lyme disease. Unfortunately, it's difficult to say 100%. This is probably the best that we can do. Treatment varies with the species. In dogs and cats, I recommend tetracycline or doxycycline as the drug of choice for the initial disease. When you first see it presented, it's an acute onset. The dog hasn't had it before. Tetracycline or doxycycline seems to work very well. Ampicillin will work, erythromycin will work. I prefer tetracycline. I have no good basis for that other than the feeling that I get from people that are using it. It seems to work a little better. If it doesn't respond to tetracycline, or if it's had it before and this is a chronic problem that it keeps coming down with it again and again, cephalexin seems to help. And this is generic Keflex. It's cheaper than Keflex. And the owners kind of balk at the price of Keflex, but they don't complain so much about the price of cephalexin. So I've been recommending cephalexin. In cats, cephalexin sometimes is the drug I recommend first. The cats don't seem to be responding quite as well to the tetracycline first. I don't know why, but they do respond to the cephalexin. So sometimes in cats, you might want to try cephalexin first. A little trick in cats, it's difficult to give pills to cats, to say the least. And it's also, people will say, well, where can you find the tetracycline capsules that are small enough? Because it's hard to find 125 milligram capsules or tablets. What you could do is you can go to your pharmacist and they will give you tiny capsules, and they will actually take the tetracycline and they can put it in the smaller capsule, 125 milligrams, so you can get smaller capsules that way. You can also get it as a liquid. And sometimes they will eat it off their food, sometimes they won't, but it's worth a try. You can also get cephalexin as a liquid, and in the cats, any way you can get it in is helpful. And so you have to come up with some tricks to try and do that. In the horses, don't use tetracycline, because what I haven't mentioned yet is you got to go a minimum of 2 weeks with whatever treatment you use. Probably go better, especially after what you hear this morning, it's probably better to go longer. But for sure not less than 2 weeks. Now, if you use tetracycline in a horse for 2 weeks or longer, you're quite likely to run into intractable colitis, and the animal may die on you from that. So you're better off with a Lyme disease. So recommend penicillin, and the long-acting penicillin, benzathine penicillin, which you only have to give once every other day, again for a minimum of 2 weeks. Now, I know that they say that procaine penicillin gives a higher level in the blood than benzathine, but for some reason the benzathine works better. And again, this is an observation on many horses that we've done. Can't explain why, but it does work better than injecting every day with procaine penicillin. Erythromycin does work in horses. We've had a couple that were young horses, young yearlings, that did not want to give injections to, that we did treat with erythromycin, and clinical signs went away and the antibody titers dropped down to negative. So it did work. You grind it up, mix it up with applesauce, and shove it down their throat, and it avoids having to give them shots, but that also worked. In cattle, you can give either tetracycline or penicillin if you want to treat an individual cow. Again, the problem is that if you treat an individual cow in a herd, she's likely to pick it back up again, because if you don't treat the whole herd, the spirochete is going to be present in the herd and being passed around in the urine. Again, you have to throw the milk out during the time you're treating and for the withdrawal period. So with the cattle, it's an economic decision as to whether it costs more to treat the cow or to get rid of the cow, and that is left up to the veterinarian and the owner to decide. Prevention, I always say wear protective headgear, and some horses you can get to do that, most you can't. So this is pretty much made up for humans, but it works for animals too. Prompt removal of the ticks, and this means going over your animal every day. If you have a pet, you can do this. If you have a dog, cat, or even a lot of horses, people see the horses every day, a lot of them, and you need to just go and you need to just feel all over their body and down their tail, because you can't always see them, and remove them as promptly as possible. Caricides. There are many products that are made for animal use that contain permethrin. You need to be careful that you use the one that's specified for the species that you have, especially if you have a cat. You can't use a lot of the higher concentrations on cats. So if you have a cat, be sure you use the one that's made for use in cats. It is helpful. It doesn't prevent all the ticks. It doesn't do much good after. If you have a horse and you're out riding it, it's very hot and it gets sweaty. It doesn't work too well after that. If it's out in the rain, it doesn't help a whole lot after that. And it doesn't last as long as a lot of the recommendations say they'll last for 7 days. It usually doesn't last that long, but it does help, so it's worth doing. It's worth putting it on. Vaccine, Dr. Johnson isn't here, but he's still working on it, but at this point there is no vaccine for animals. And I think particularly in the dairy cows, this is going to be the only real help in treating and prevention of it in cows because of the very extreme difficulty in attempting to treat an entire herd. That's all I have. Are there any questions? Yes? Yes? Yes, it's very similar to the dogs. I didn't show you, we have the number of animals we tested last year. We had 2,000 some positive dogs and 40 positive cats, which gives you an idea of the difference in the numbers. I don't know if that's a difference in resistance or a difference in behavior. Cats are not like dogs. Cats are very secretive. In general, it's outdoor cats that get Lyme disease. It's not your house pet. Because in general, right, but when the cat is sick, if it's an outdoor cat, a barn cat, if it's lame, most people won't pay attention to it. They won't come up to you and hold their leg up like a dog will. So you might not see the early stages. You might not see the early fever. You might not see the early lameness. What you see is when they get very, very sick. And what we've seen is cats with chronic weight loss that are very sick, cats with glomerulonephritis, cats with pleural effusion with heart disease. And also you do pick some up with the lameness, but I think part of it is cats' behavior is different. And again, it's outdoor cats and not as much house pets that are looked at that are getting it, because sometimes you have cats that never go outside, and those are the ones that people really pay attention to. So I think there's it's hard to say whether it's strictly resistance in the cat or behavior of the cat. But they do indeed get ticks on them, and they do get Lyme disease. Yes? Oh, neat. Sorry, it's not neat, but it's exciting. Yeah, that's really interesting. Yes? We've isolated it from dog urine, and we did the same experiment. We put an uninfected dog into a room with an infected dog, and after a month, the uninfected dog developed antibodies and never got sick, but it did become infected. So it can be transferred that way, and I think in kennel situations this may be a problem. Boarding kennels, that type of thing. It's not as much of a problem as in dairy cows where they're always crowded together like that. That have Lyme disease, as far as I recommend treating them. Yeah, I recommend that they treat the dog that has it, check the other dog, see if it has antibodies. They may want to treat it, they may want to wait and see if it becomes infected. As far as themselves, the possibility exists. I don't think it's tremendously high because of the number of people that have infected animals that we know of that have developed Lyme disease after the animal's gotten it. We have a lot of people that come in that are sick at the same time as their dog, or that were sick before their dog, and it suggests they go out and take walks in the same place. We haven't seen that many have gotten sick after their animal got infected. It's theoretically possible, and to try and avoid contamination with urine. If you have small children, that might be a worry because they're more likely to come in contact with urine. I think with normal sanitary precautions,